Hi, I'm Dr. Rahman, and welcome to Black Women's Health Podcast. I was first impressed with ChatGPT when it planned and detailed my road trip, including the last minute changes which were required due to Hurricane Debbie in August of 2024. Since then, I've used ChatGPT a lot. I've seen it be awesome. I've seen it be wrong. I've seen it hallucinate. And so, with the increasing use of artificial intelligence in healthcare, it's while it's promising, the question comes up, or the questions come up, is it safe? Can we really trust it? Is it racist? Now, the term racist may be triggering for some, and I don't want that to be. But it is a question worth considering given given this recent study that I like to reference. The study was from MIT scholars. This study was presented in Athens, Greece this past June. The study looked at the impact of non-clinical information on the clinical diagnostic recommendations by LLMs, large language models. It concluded that non-clinical information about a patient can impact the clinical diagnostic treatment recommendations when using these large language models, these LLMs. The large language models, you're familiar with them. They're Chat GPT, they're Bard, Claude, GPT-4. These are types of artificial intelligence that focus on understanding, predicting, and generating human-like text. Apparently, it's been around for decades, but we, the public, did not get access to it until 2023. And since then, its use has become widespread. In the clinical setting, LLMs are increasingly being used to help with chronic disease management, radiographic diagnostic assistance, patient chart documentation, medical billing, and patient communication. And so, in so many ways, LLMs are great. It has the potential to help relieve physician burnout. It has the potential to help address physician shortage. Doctors who are listening to this may well be aware of Epic, the electronic medical records that are used by healthcare systems throughout this nation and are present in many hospitals. Epic has been using LLMs to assist with patient communication and the generation of clinical notes. But have we taken the time to consider what do we do when it's wrong? What do we do when it hallucinates? What do we do when it's inconsistent? What do we do when it's biased? The study that I mentioned earlier concluded that non-clinical information can and does affect LLM's treatment recommendations. Non-clinical information impacts clinical recommendations. How, if the clinical information doesn't change, the diagnostic recommendations shouldn't change. But what they found that if certain non-clinical information was changed, such as changing the language, how the information was relayed, whether the language was colorful, emotive language, or was it anxious, uncertain language, how it was relayed, or even changing the sex of the person or not mentioning the sex of the person, way the message is actually delivered, whether there are typos or white spaces, or whether the message is all in lowercase or uppercase, that non-clinical changes actually resulted in changes in the treatment recommendations. Why? Why should that happen? Why should that be the case? And if it makes no sense, if the clinical information remains the same, then typos or the way the message is expressed shouldn't result in a change in treatment. Female patients were disproportionately advised to self-manage and to avoid seeking clinical care. So this study, which was presented in June of this year, did not specifically look at race, but it raises a lot of questions. It raises questions about the effect of race, but more importantly, it raises the question of how do we fully evaluate the use of LLMs in healthcare, and how do we evaluate how LLMs process information when they are determining clinical recommendations. This is Dr. Rahman. I will actually leave a link to this study. It's worth checking out because it makes you wonder.